Good afternoon and welcome to our Learn and Share conference call. I'm Russ Derry, Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for today is rescue medications for epilepsy, and we're pleased to have as our speaker Dr. Louis Dang, who is a pediatric epileptologist with a comprehensive epilepsy program at Michigan Medicine CS Mott Children's Hospital. Dr. Dang, could you briefly introduce yourself, talk a bit about your clinical and research interests, and describe your experience with this topic?
Great. Thanks, Russ, and thanks for the invitation to be part of this discussion. I hope it's helpful for the participants. Like you said, I'm a pediatric neurologist with a specialty in epilepsy, and I work at Michigan Medicine. I did my medical school and grad school training at Johns Hopkins University. And for my grad school, I did my PhD in studying neural stem cells and brain development. I then moved to Michigan and did residency and an epilepsy fellowship at University of Michigan, stayed on the faculty. And these days, I'm mostly doing research in the lab, studying how genetic variants can cause epilepsy. We use human stem cell models to model the epilepsies. And clinically, I read EEGs, take care of our hospitalized pediatric neurology and epilepsy patients, and I see kids in the epilepsy clinic alongside our team of nurse practitioners, residents, and fellows. So that's mainly my experience with rescue medications that's on the clinical side and prescribing it for our families and children.
Okay, great. And do you work in Dr. Parent's lab, or is that a separate
I do,
lab?
yeah. So
okay.
My research lab mentor, Jack Parent, we work very closely together.
Great. Okay, so can you start by briefly explaining what we mean when we use the term rescue medication?
Sure. So most seizures are relatively brief, like less than 5 minutes, but some are prolonged and don't stop without administering medications. And these rescue medications can be given to, as needed, to stop seizures when they occur and to try and prevent a seizure from progressing to a seizure emergency. And it's notable that they're distinct from the daily medications that patients with epilepsy will take. Those are to try to prevent seizures from happening. The rescue medications are given as needed.
Okay, great. And can you discuss status epilepticus and acute repetitive seizures and why rescue medications are prescribed to stop or prevent these occurrences?
Sure. So like a lot of things in medicine, seizures can fall on a spectrum of how long they last, how frequently they occur, and it can be related to how much harm they can cause too. Again, like I said, most seizures last less than 5 minutes and stop on their own. The term status epilepticus refers to seizures that continue and don't stop on their own, and we now practically define them as seizures that last more than 5 minutes. So that's the time point at which many seizures, if they haven't stopped by that point, they'll continue to progress. And one key point is that the longer a seizure persists, the more refractory to treatment it will be. So the longer it lasts, the harder it will be to give a rescue medication that will stop it. And when a seizure isn't stopping on its own, we usually consider this an emergency and start treatment as soon as possible. It's also known that the longer a seizure can last, the longer it may take for that individual to recover from the seizure. So we want to make those seizures shorter. That said, also giving the rescue medications can cause sleepiness and lethargy that can add to the recovery time. But the reason we want to treat status epilepticus is that it can lead to significant problems, so morbidity and mortality, hospitalization. Sometimes people need help with their breathing, so they need a breathing tube in. It can lead to a stay in the ICU, and it can also be life-threatening. If you look across studies, the mortality rates in children are around 3%, but it can be up to 20 or 30% in adults. So you also asked about acute repetitive seizures, and again, status epilepticus can fall on a spectrum of severity. So we can define it as, or some different subtypes might be convulsive status epilepticus, or when a generalized tonic-clonic seizure continues and doesn't stop. You can also have brief, repeated convulsive seizures that each stop on their own but are happening so frequently that that person isn't coming back to his or her baseline or usual self in between the seizures. That would also be considered status epilepticus. And there's also something called non-convulsive status epilepticus, where someone might be semi-responsive or in an epileptic twilight, you call it, and that can be followed by continuous or repeated focal seizures. So this is less severe on the spectrum. You can have continuous or repeated focal seizures that don't actually cause altered awareness, but that would still be called status epilepticus, and it has a specific term called epilepsia partialis continua. That might look like just someone having a twitch in their thumb, for example, that continues without stopping, but also being perfectly aware and conscious and able to speak. So status epilepticus in itself has the spectrum of severity, and this also correlates with the amount of harm that could come from the seizures. Generally agreed that the damage to the brain cells, the neurons, can occur when convulsive seizures last 30 minutes or more, but that the less severe forms of status epilepticus are also less likely to cause neuronal damage. So on the even less severe side of the spectrum, but still a serious issue, are acute repetitive seizures. And there are a lot of different definitions for acute repetitive seizures, and the doctors and researchers can't all decide and agree on one. Some people also call these seizure clusters or flurries of seizures. And generally speaking, it's seizure activity that's abnormally higher than that individual's baseline seizure frequency. And some people have defined it as 3 seizures in 24 hours, or greater than or equal to 2 in 24 hours, or 2 to 4 seizures in 48 hours. Some people say it's 2 generalized tonic-clonic seizures, or 3 focal impaired awareness seizures in short succession. So there are a lot of different definitions for that, but it's on the same spectrum as status epilepticus, but kind of defined a little bit differently.
And generally, I would assume with acute repetitive seizures that the potential for any kind of brain injury or mortality is lower than with status epilepticus in general.
That's correct, yeah. So
yeah.
Less dangerous than convulsive status epilepticus, but still serious enough that we often try to treat, sometimes with rescue medications, to try to kind of decrease the seizure frequency and prevent it from progressing to status epilepticus.
Right. Okay, so are rescue medications ever prescribed for non-convulsive status epilepticus, or is this kind of too difficult to recognize in the community setting, or perhaps not enough of an emergency to warrant such a prescription?
Great. So just to review, convulsive status epilepticus is when you have a convulsion, shaking, stiffening that might be related. Non-convulsive status epilepticus don't have convulsions alongside, so that could look like frequent or prolonged absence seizures, where people are just not as responsive as they usually are, or they could be unresponsive but not, but still have their eyes open, could still move around, for example, potentially. You can also have prolonged focal seizures, so seizures that are confined to one spot in the brain that cause altered awareness but don't cause convulsions. So there might be confusion, there might be a loss of the ability to understand or produce speech, so aphasia. So these are all examples of non-convulsive status epilepticus. And to answer the question, yes, rescue medications can be prescribed for non-convulsive status epilepticus, but as you pointed out, it can be difficult to recognize in the community setting. The main problem is that a recovery period after seizures, like the post-ictal period, can also resemble non-convulsive status epilepticus. So often it takes caretakers or close friends, family, to be cognizant and aware of that individual seizure types to be able to help in this regard. And there's some patients that have non-convulsive seizures frequently, and there are other patients that typically have convulsive seizures. So the reasons we want to treat typically are that non-convulsive status epilepticus, which again may be considered less severe than convulsive status epilepticus. The non-convulsive can still progress to convulsive status epilepticus. And again, if you wait to treat, then sometimes it's harder to treat the longer it's been going on. But it's difficult to determine when to treat. It's an individualized decision, I think, for each patient and for what the characteristics of epilepsy are in that particular patient. For example, if most people treat convulsive status epilepticus at the 5-minute time point, I might wait 10 or maybe even 15 minutes before treating non-convulsive status epilepticus, just because sometimes people have non-convulsive seizures that last 10 or 15 minutes that then still stop on their own without needing medication treatments. So it depends on the situation.
Right. And you mentioned the mortality rates for status epilepticus. Is that for the general population, or is that for the statistics you cited, or is that for people with epilepsy? I imagine that it's the rate. If you were giving the general rates for the overall population, the rates among people with epilepsy are lower because it's excluding cases of acute conditions that are very life-threatening that can lead to status epilepticus?
That's correct, yeah. So the stats that I gave were for all comers, and the up to 20 to 30% adults is even more specific, or for all comers that have had seizures lasting already greater than, I think, 15 minutes or something like that. So like you mentioned, in someone without a history of seizures, status epilepticus can be provoked by something underlying that's much more serious, like acute meningitis or like an infection of the brain and the covering of the brain, or you can have it from brain trauma or head trauma. So the underlying cause of the status epilepticus could be what's very damaging and what leads to those relatively high mortality rates.
Got it.
And these are also older studies for us, so I think also we have better protocols and medications and supportive treatments for status epilepticus now. So I think in my experience, the mortality rate seems a lot lower than those stats that I quoted before.
Right. Great. So what are some other situations in which rescue medications may be used besides status epilepticus and acute repetitive seizures?
That's a good question. So in individuals that have a predictable cycle to their seizures or have a clear pattern to when their seizures occur, then you can use a rescue medication to add to the daily medications around the time of higher seizure risk. So just as a side note, epilepsy and seizures are a very sporadic disease, meaning the seizures usually happen at pretty unpredictable times. And one of the problems with our medication treatment is that we just treat all the time, which is what is necessary to do given our armamentarium of seizure medications. That's how they work. They just have to be on all the time. The ideal treatment, you might think, is actually that if you can predict when a seizure is about to happen, you give a medication right at that time to prevent that seizure from happening. So you get the benefits of seizure prevention without any of the problems of having medications on board in between the seizures when you might not necessarily need the medications, and that would be decreasing the amount of side effects that you might get from medications. But there are some conditions that have a pretty predictable cycle. So catamenial epilepsy is one. Catamenial epilepsy refers to women with epilepsy who have their seizures cluster around the time of their menstrual period because of changes in hormones. Estrogen and progesterone cause changes causing a lower seizure threshold around that time. And in those individuals, hormonal therapy can help, or sometimes adding a low dose of a rescue medication around the time of menstruation can help. A lot of our children have a lot of infectious illnesses, colds or whatever, and their seizures can increase around the time of illnesses or fevers. So a common practice that we do at U of M and other places too is we have a bridge of a rescue medication. If they seem to have a ramping up of their seizures during that time of illness, we might give a low dose of an oral rescue medication such as clonazepam or Klonopin, just to get over the hump while they're sick. And the main drawback with this is that, or the reason I sometimes am hesitant to do this is that a lot of patients get sick but don't always have increased seizures with their illnesses. So that proactive rescue medication might be unnecessary. And also that medication can lead to additional side effects like sleepiness and lethargy. So if you have a child that's already kind of lethargic and sleepy and miserable because they're sick, and then you add on top of that some clonazepam, which makes them more sleepy, that can make them seem even sicker or have them have problems of waking up enough to stay hydrated. Same issue with or similar situation if you have a type of epilepsy where you always can kind of feel your seizures coming on for a day before, or even some people say 2 or 3 days before, and you have these warning symptoms before seizures, then you could consider taking some rescue medications to try to prevent those seizures from happening during those times where you're predicting that you might have seizures. Of course, with good instructions from your personal neurologist. The other situation is sometimes if we're changing the long-term medications or daily medications and switching from one medication to another, then breakthrough seizures can occur during that time, which is not an abnormal phenomenon. But if those seizures are ramping up too much, then we could add on a temporary rescue medication to, again, bridge the gap between that transition and daily long-term medication.
Right. So, and presumably there are no rescue medications that are fast-acting enough to be able to use if a person has an aura or a focal aware seizure, where they could take it and then it would potentially prevent the spread of that seizure to either a focal impaired awareness seizure or a focal to bilateral tonic-clonic seizure. There's not enough time for that to act. Is that correct?
Well, I think for most individuals that's probably true, but we do see some patients that have an aura that lasts minutes, and during those minutes, you could take whatever rescue medication, and some of these rescue medications can act quick enough to prevent things from regressing, or even if they act on the order of a few minutes, then when it gets in your system a few minutes from the time you take it, at least it's better than if you were to give it after evolving to a bilateral convulsive seizure, a big tonic-clonic seizure. So at least it gets in the system earlier than later. So I think it's a potential, but it's not the common situation.
Okay, great. So what are the various factors that neurologists consider when deciding whether or not to prescribe a rescue medication?
Great. So it's a lot of different practical factors that I think about. And I think the first message is that, one, the physician or provider has to think about it. So if that thought hasn't crossed that provider's mind, then then you'll never consider actually starting a rescue medication for a patient or family. So first, you just have to think about it in general. Does this family or patient need to have a rescue medication or want to have a rescue medication on hand? But it is an individualized decision. The practical issues are, depending on the type of epilepsy. So in more severe or refractory epilepsy, then I might be more and I would think that a rescue medication would be more likely to be used, so I might be more inclined to prescribe one. If there's a history of status epilepticus or prolonged seizures or severe seizures, if the seizures always cause the patient to stop breathing, for example, then that might be a reason to give a rescue medication. There's patient and family preference. really want to have something on hand and feel empowered by that, and that's a consideration. And some people say, no, I don't want to have to deal with this. I just want to call 911 and get medical help from people that are professionals, and that's a consideration too. If they are really far from emergency care or a hospital, though, then I might push more strongly to have a rescue medication on hand, just so that while the ambulance is headed to their house, then they can at least start some treatment. Again, early treatment is better than later treatment, typically. Age is also a factor, so very young children, meaning infants that live close to medical care, it might be preferable for the rescue medications to be given under medical care, or by the EMS folks rather than by the caregivers at home, because often these rescue medications are not the doses aren't as clearly defined, and the safety is not as clearly defined in very young kids without proper monitoring. Cost is also a consideration. So depending on the type of rescue medication and the insurance, these rescue medications can be unexpectedly costly. So some folks decide to forego the rescue medication, just weighing the cost and benefits of having it.
Okay. So roughly what percentage of pediatric patients would you estimate are prescribed a rescue medication, and how does that percentage differ in adults?
So this is a bit of a guess just based on my experience,
Sure.
but I'd say something like 2/3 to 3/4 of my pediatric patients have a rescue medication prescribed. In adults, I would guess less. A lot of these rescue medications need to be given by somebody other than the patient, right? So if the patient is having a convulsive seizure or status epilepticus, they can't self-administer the medication. So if there are adults that are under constant supervision, or there are lots of children that are under constant supervision, then it's easier. In adults, I looked at some studies that look like it's as low as 10% of adults might have a rescue medication prescribed. Doesn't mean that, and it seems like it should be higher, meaning there are plenty of adults that can have coworkers or family members around that might be able to administer that rescue medication as needed.
Right. Okay, so now let's talk about the different types of rescue medications. First, what are benzodiazepines, and which ones are most often used as rescue medications? And then what are the benefits and limitations of each possible route of administration?
All right, so feel free to interrupt, Russ, because this is a big question. Just keep me on track. So
take your time.
Rescue medications are typically in the benzodiazepine class of medications. Benzodiazepines, you can recognize them because the generic names often end with Zapam or Zolam. So, for example, Lorazepam, Diazepam, Midazolam, or Clonazepam. Benzodiazepines work on the GABA receptor. So in the brain, there are two main. There's one main excitatory neurotransmitter or chemical, and there's one main inhibitory neurotransmitter or chemical. GABA, or GABA, is the inhibitory neurotransmitter. So these benzodiazepines try to inhibit neural activity in the brain and calm it down. If you think of a seizure as excessive neural activity, then these benzodiazepines try to bring that activity down. As you mentioned, there are lots of different routes of administration, so they can be administered orally, and when it's oral, it can absorb through the cheek or under the tongue, so buccal or sublingual. It can be administered orally and swallowed, so through the gut. And then there can be rectal administration, so it absorbs through the rectal mucosa. It can be delivered intranasally and gets into the veins and capillaries in the nose. And they're typically designed to be used by people that don't have medical training. They also can be given by people with medical training as injections into the vein. so intravenous or injections into the muscle or intramuscular injections. And right now, there aren't really intramuscular injections that are given by people without medical training, but that's something that's trying to be developed, kind of like an EpiPen, where you would have an auto injector that you could put into someone's muscle. So to talk about the specific rescue medications, Lorazepam is also known by the brand name of Ativan, and it's available as an oral medication, a buccal absorbed medication, meaning through the cheek, or sublingual under the tongue, or IV. It has so when we think about these medications and the different routes of administration, they have different delay times for action. And I'll get into that a little bit, but also the medications themselves, because of their different chemical properties, have different rates of distribution into the body, and they have different rates of elimination from the body. So that for a rescue medication, the ideal is that you want it to be quickly absorbed and quickly distributed to the brain. And depending on the situation, you might want it to be kind of slowly eliminated from the body, meaning if you want a longer period of protection from seizures, you want it to be slower. But if you want it to be a quick elimination from the body, that might also be helpful to minimize that amount of sleepiness and lethargy caused by the medication administration. But again, that kind of leaves the brain less protected or not as protected for as long a period of time. Sorry, I said that wrong. It leaves it protected for a shorter period of time if it's eliminated quickly. So Ativan has a distribution time into the body of about 10 minutes or so, and it takes 8 to 25 hours for half of that medication to be eliminated from the body. So relatively longer elimination time. And the IV form, the intravenous form, is approved by the FDA to be used in adults for status epilepticus. The next one is Diazepam, otherwise known as Valium when it's given orally or IV. It's also known as Diastat when it's given rectally. That's the brand name. And then there's a new one that I'll talk about later, Valtoco, which is intranasal Diazepam. It's also quickly distributed through the body, so 1 to 4 minutes it should be mostly distributed through the body, and it's also very slow in being eliminated. So 1 to 2 days of half the amount will be eliminated from the body. And Diastat and Valtoco are both FDA approved for seizure clusters. The next one is Midazolam. This is also known as Versed, and it's one that we often use intravenously in the hospital to control seizures. It's also used, and for sedation and anesthesia, also used a lot by EMS intramuscularly. And recently it's been approved by the FDA in the brand name of Nasolam for intranasal administration. Midazolam is probably the fastest on time and off time, and its distribution is within 2 to 4 minutes. And its elimination is between half an hour and 4 hours from the body. So it is quicker off time, which can help in terms of if you don't want that as long of a lasting sleepiness or lethargy with the medication administration afterwards. And then the last benzodiazepine that we use for rescue is clonazepam, or Klonopin is the brand name. And this is available orally or as oral dissolvable tablets. And its distribution is relatively slow. So it can be 1 to 4 hours or so that you get the max level in the blood. And it's also slow to be eliminated, so 30 to 40 hours. So this used to be a pretty common medication that was a daily medication for seizures. People don't use it as much anymore for daily medication, but we can use it for seizure clusters or a bridge during times of illness or a bridge in times of increased seizures with the daily medication transitions. Again, with the longer on time and off time, it's good for those situations. So, and just pause there, Russ, and before I go on to the routes of administration and talking about those, is there anything else that you wanted me to cover for those specific medications?
No, that's great. That's great. So yeah, maybe just again talk about pros and cons of each route.
Great. So again, the ideal is a fast on time or a fast fast absorption into the body and to get to the brain. IV intravenous is the fastest, so it's 30 to 60 seconds delay time for it to work. But intranasal is also very fast too because of the rich blood supply and direct route to the bloodstream through those vessels in the nose. So 1 to 5 minute delay time for action. It's also a relatively easy and safe and convenient form of administration. The disadvantages or potential disadvantages with intranasal is that you have to think about the head position when you give it. It can cause irritation in the nose. And individuals that's not cooperating with intranasal administration, it can be difficult to give, meaning if they're fighting off and the caretaker putting something up the nose. And you also need open nasal passages if you have a lot of congestion or something like that might be a problem. And something that had been a problem in the past is that you can only give a small volume of liquid intranasally, so the medications have to be relatively concentrated. But with Midazolam and Valtoco administration, that's not so much of a problem anymore.
Yeah, and just to jump in there, is to what extent, I guess, with the older form of administration of intranasal midazolam versus the two new medications, to what extent has the issue of swallowing some of the medication, if it's not properly aerosolized, has that been improved with the new formulations?
I am not sure, Russ, to be honest. We have had relatively limited experience in Midazolam so far because we've just sort of recently been starting to use it. So I'm not really sure if people have had problems with that, with the swallowing aspect.
Okay.
Yeah, so both Midazolam and Valtoco are relatively new. We've prescribed Midazolam fair amounts in our practice now, but I think it'll take some time before we get feedback from our patients as to how well it works for them and how they like it. Valtoco we actually have not yet prescribed, but don't see why not in the near future. So talking a little bit about sublingual and buccal administration. So this is not something we do as frequently, but it can be a good route of administration because it's also a relatively fast onset time of 3 to 5 minutes. And these medications can dissolve easily or be available as a liquid or a gel or in development as a strip that will kind of melt under the tongue or on the cheek. If there are pills that are absorbed this way, you don't really need refrigeration, which is great, but if it's a liquid, then it may need refrigeration, and it can be relatively easy to carry around for patients or caretakers. It can be a problem if it irritates the mouth. It can also be a problem if the patient swallows it because then you don't get that fast absorption to the blood vessels in the mouth. And also, of course, if there's a larger convulsive seizure, then there's a risk for aspiration, and there's a risk to be bitten if you're administering the medication. So I think those are the main reasons why I don't prescribe that type as much for status epilepticus, but it can be useful for example, if someone has an aura and they're able to self-administer and try to prevent that seizure from progressing much longer. Intramuscular, again, that's more for medical professionals at this point, but onset is 10 to 20 minutes. Rectal administration, time to action is about 5 to 30 minutes, and it's been pretty broadly used because Diazepam was the first FDA approved for out-of-hospital use in 1997, so it's been around for quite a while. It's really been the standard for rescue. You can give it to a conscious patient or an unconscious person, has rapid absorption. It doesn't have any of the problems if you become nauseated or vomit with a seizure. Then that medication, an oral medication might come back out, but this will not. The disadvantages are that to some people it's not as acceptable, meaning especially like the social acceptability of a rectally administered medication. You often need someone else to give it, but some people are also able to self-administer, and it can be very difficult in larger individuals or even individuals in a wheelchair, and it's hard to move them in order to give the medication, and that can be difficult. And then finally, the oral ingested route, so into the gut, route of administration is the slowest. It takes 30 to 90 minutes for the delay to the time of onset for that medication to work. And again, it's more used not for status epilepticus or acute repetitive seizures, but if you're having an increase in the baseline seizure frequency and you need some sort of bridge for a few days or for a week or something like that, then that might be a good route of administration.
Okay, well done. A lot of good information there. So with the recent release of the two intranasal formulations, and I think you've touched on this a little bit already, but can you briefly discuss the factors that might cause you to prescribe one versus the other, and talk about the eventual impact of these medications on the use of Diastat, because, as you mentioned, that has been kind of the standard of care, but now that this is by many will be seen as a preferable route of administration, can you just talk a little bit about that as well?
Sure, yeah. So again, 3 FDA-approved medications for status epilepticus or acute repetitive seizures. That's Diastat, which is rectal Diazepam, Valtoco, which is intranasal Diazepam, and then Nasolam, which is intranasal Midazolam. So Nasolam is FDA approved for 12 years old and up. So there's under 12 years, we don't typically prescribe it. Or I should say, we don't prescribe Nasolam, the brand name. We have been giving intranasal Midazolam with a syringe and an atomizer even prior to Nasolam's approval for a number of years, as have a lot of different providers, and we do give that to younger ages too. Some of the differences, again, Nasolam or Midazolam has a faster on time and off time potentially, or especially its off time. And its administration is typically one dose, and you can repeat the dose in 10 minutes if the physician prescribes it that way. And it's advantageous a little bit in that we have a lot of previous experience with the generic form of it compounded and given to the patient. So we kind of, in a lot of our patients, we kind of know how they might respond. One major difference also, though, is that it's only given as a 5 milligram dose for age 12 and up. It's not a weight-dependent or age-dependent dosage. That's as opposed to Valtoco, intranasal Diazepam, which is age and weight-based dosing, very similar to how Diastat is given, which is also age and weight. So because of that, you might actually, to get to the correct dose, you might need 2 different nasal sprays to give to that individual. It also has a more broad range of ages for FDA approval, so age 6 and up. And this can be, the other advantage is that Diazepam, we have a long history of knowing how it works with the rectal form, with Diastat. And we have a lot of patients that respond well to rectal Diazepam, and you might say that they probably respond well to intranasal Diazepam too. With Valtoco, the prescribing instructions are that you can give a second dose, but you have to be at least 4 hours out from that first dose to give that at home. So there are a few small differences in terms of the dosing and the timing of the second dose, and of course the medication itself is different between Nasolam and Valtoco. I think there has been a mass exodus in some ways away from Diastat, but we still prescribe Diastat pretty commonly. But I think the mass exodus has been gradual over the past few years as we've transitioned a lot of patients to intranasal midazolam rather than Diastat. But I do have a few patients that I've transitioned, and then they said, well, the midazolam didn't really work for our child, so we go back to Diastat. And some of that might be having to do with the different medications. So again, since midazolam is fast on and fast off, sometimes people need a longer period of time that they are that they have that benzodiazepine in their system. So Diastat might be better in that regard. There's also a lot of other practical issues like insurance issues. So some of our families have been prescribed Nasolam, and even though their insurance would cover it, their copay was really high. I think each of the companies have on their website programs that can help families pay for them, so that would be something to check out if families and patients are having that problem. But like you alluded to, Russ, the major advantage that families see is that it seems a lot more socially acceptable and easy and convenient to give something intranasally rather than rectally. But again, there can be other issues like having problems with correct administration and stuff that should be also considered.
Great. So do you anticipate increased use of rescue medications among adults in response to the availability of these intranasal medications?
I think so. I think for a couple of reasons. One, if there's an adult with focal epilepsy that they can kind of sense their aura and their aura lasts long enough that they can get to their rescue medication, it seems a lot easier to do self-administration with an intranasal medication than a rectal medication. Again, the social acceptability aspect that people see in it would be a big issue. And this is true also for older children that are in school. Those children and the families of those children don't want their kids necessarily to have to have a rectal administered medication in the middle of a classroom, but an intranasal administration might be a lot more acceptable to them. So, yeah, I think so.
Okay. And are there still circumstances in which you might prescribe the older method of giving intranasal midazolam using the syringe and atomizer?
Yeah, I'm kind of guessing at this point, but I could see a few circumstances. So one is if the insurance, for some reason, is better covered under the older method of using generic midazolam with a syringe and atomizer, and if it were a lot more affordable for the family, that could be one thing. The other major issue is that when we've been doing the older method, we just use a certain dose that's weight-based, so 0.2 milligrams per kilogram to maximum of up to a maximum of 20 milligrams. And the Nasolam is a set dose of 5 milligrams for age 12 and up. So if the kids are younger too, then that might be another, younger than 12 would be the other situation where we would potentially use the older method. Or if we thought that 5 milligrams was not enough for that individual, then maybe we might have a better adjustable dose by using the older method.
Okay, great. So what are some of the key risks patients and families should be aware of in using rescue medications?
Great. So the major thing that patients experience is somnolence or sleepiness or lethargy. And in the studies of Diastat, about a quarter of the patients were sleepy with Diastat. Benzodiazepines can cause respiratory depression or slowed breathing rate, and that's especially true with concurrent opioid usage. So those two medications together kind of synergistically decrease that respiratory drive. So that's why in a lot of our patients that are receiving a rescue medication for the first time, we still recommend that 911 be called at the same time. Or if someone has needed repeated doses of rescue medication, then they might need more closer monitoring by medical personnel for respiratory depression. That said, in studies of diastats, slowed breathing didn't seem to be a major problem, so it happens, but it's not a very common thing that we see with a single dose. Some of these medications, as they're all designed to be given by non-medical personnel, they can be administered incorrectly. So for a rectal medication, you could imagine that it might be administered without correctly inserting the syringe into the rectum. Or, the correct, I guess I could just go over what the correct administration is for diastat. So typically you would confirm the dose and see that there's this green band on the syringe that says that it's ready to give, and you turn the person towards you, typically with their upper leg forward, and you would expose the buttocks by pulling down their pants or shorts, and you'd insert the syringe, push the plunger in slowly over 3 seconds, hold it there for 3 seconds, and then as you take out the syringe, you hold the buttocks closed for at least another 3 seconds to prevent that medication from coming out. So you could imagine how incorrect administration might lead to that medication not being actually delivered to the rectum or coming out right after it's administered. Similarly, with intranasal administration, you could have problems with missing and not having the medication go into the correct place. Overuse or addiction can be an issue. So these medications are for as-needed use with seizures, but of course we have some patients that have very frequent seizures and seem to need rescue medications all the time or every day, and that can be a significant problem because with chronic benzodiazepine use, then the body can become tolerant to that medication and it might not be able to work as well with repeated use. And there's also a concern for addiction. So all of these medications are controlled substances and have addiction potential. So that's also a concern in patients too.
Okay. So, sorry, were you going to say something?
I think those are the major concerns.
Okay. So rescue medications are typically prescribed as part of a seizure response plan or seizure action plan. Can you briefly describe what a seizure response plan includes and the types of instructions that are typically given on administration of rescue meds?
Great. So we try to give all of our patients a seizure action plan that they can use for themselves, for family members, for the school. And that basically is an individualized document to give to somebody else to tell them about the epilepsy and what to do in case of a seizure. There's some really good examples of seizure action plans on epilepsy.com. So the things that are typically on these plans are name and contact information, types of seizures and descriptions of those seizures, how to respond to a seizure, including what first aid procedures to do for a seizure, when to call 911, when to call the patient's provider, and when to use rescue medications. And this type of instruction should be pretty explicit and clear, meaning if this happens, then give this dose and how much to give. Most patients, if they have a rescue medication, just have one, but there are some patients that have two rescue medications. For example, one for a convulsive seizure lasting greater than 5 minutes, you might give Diazepam or Midazolam or Valtoco. But if they have a few focal impaired awareness seizures within 6 hours, then you might not need, a big dose of Diazepam. You might give a small dose of Clonazepam because they're still coming back to the normal selves in between the seizures, and they're awake enough to take an oral medication, so you might give this medication. So that those instructions should be relatively explicit. And then care after a seizure is important. So what to do after a seizure is over, what to expect. Special instructions for EMS or for the emergency room. So some patients, for example, have specific medications that they respond well to, or medications that they don't respond well to, or a certain dosage that's typically used for that patient, and those could be good instructions on the seizure action plan. And then other information, such as what their daily seizure medications consist of, whether they're on a specialized diet, like the ketogenic diet, whether they have a vagal nerve stimulator in place, whether they have any medication or other allergies, and then a list of healthcare contacts would be important on that sheet.
Okay. And are there particular uses of rescue medications that involve more clinical judgment and are harder to train lay people to use? And if so, how can such uses be effectively incorporated into a seizure action plan?
Yeah, that's a great question and a situation that we encounter pretty frequently. And it's tough because with clusters of absence seizures or clusters of focal impaired awareness or focal aware seizures, you don't necessarily have to give rescue medications, but sometimes if you know that if you're having in a certain individual, they have a cluster of absence seizures, that they're going to proceed to go into absence status epilepticus, where they're not very responsive for a prolonged period of time, then that might be an appropriate usage of the medication. So it really is a individualized discussion with the patient and family as to what the seizure history is and when to most appropriately intervene. And that can be hard to put into a seizure action plan, but again, just explicitly stating if this, then that would be the best way to put that into a seizure action plan. There are some other situations like patients with frequent myoclonic seizures that often happen in clusters. So it varies. So if there's someone with myoclonic seizures and you know that each time they have a cluster of myoclonic seizures, they go on to have a big generalized convulsion, then that might be a good time to give a rescue medication before they progress to a generalized convulsion. But there are some patients that just have frequent myoclonic seizures that never progress to a generalized convulsive seizure, and in those patients, it might not be needed to give rescue medications. Similarly, with epileptic spasms, I've seen some providers give rescue medications for big clusters of epileptic spasms, but we also know that that's the way epileptic spasms happen. They happen in clusters, and they don't typically progress to a big convulsive seizure, convulsive status epilepticus. So maybe it's not needed to give rescue medications in those cases too. There are also people that have movements that resemble seizures but are not. In some cases, those can be non-epileptic seizures or non-epileptic events. And some of those individuals also have epileptic seizures in addition to the non-epileptic events. That can be a tough situation to decide when to give rescue medications or not. And it can be important to try to determine one way or another whether the events are epileptic or non-epileptic. So it's best to have a seizure action plan that's very specific, but it can be very challenging, and it takes a lot of inputs, I think, from the patient and from the patient's caregivers to develop an action plan that makes sense. And sometimes I just say, I have a discussion with the family, say, when would you give this medication? And when do you think it would be appropriate? Usually people have a pretty good sense of when things are getting to a point where it might turn into a seizure emergency, and that's when they would give the medication. And that's a good shared decision and discussion to have between the provider and the patient or family.
Right, that's a great point. Okay, so in many seizure action plans, particularly those used in the school setting, calling 911 may be recommended after administering the medication. So if part of the point of rescue medications is to prevent unnecessary ambulance rides and ER visits and hospitalizations, why is this often the case, and should it be?
Great. So this is also a really great question and a tough question, and often depends on the individual situation, meaning depends on the patient and the nature of their epilepsy and seizures, also depends on the school or workplace or wherever. So I think there are a couple points. One is that it is a good idea to have someone who has training in first aid or CPR around when the med is given, but of course that's not always possible. You know, not every school has that available. Not every school has a school nurse. And it's also important to know that 911 is not necessary to call in all cases. But it's hard to make that as a directive from as a family member or as a provider to the school or workplace, because it really depends on the comfort of the people at the school, and they kind of have to still rely on their judgment in the moment whether things are safe or unsafe and progressing in one direction or another. I think providers can certainly help by providing specific instructions, and of course you folks, Cindy and Epilepsy Foundation, are very helpful in talking with schools and trying to figure out what the level of comfort is and when it might be most appropriate to call or not to call 911. But I guess the point is that there are some patients that have frequent prolonged seizures that require rescue medications, but then after the rescue medication is given, they come back to their normal selves and can be productive and carry out the rest of their day at school or workplace. There are some that have very infrequent episodes of status epilepticus, and it's not as well known how well they respond or poorly respond to rescue medications, and maybe they could use more close medical monitoring for any slowing and breathing, or maybe they need medical evaluation to try to figure out why at that point they went into status epilepticus, if there's something else going on, underlying medical condition. For example, if a child has hydrocephalus and a BP shunt in place, and they go into status epilepticus and they're given rescue medications and they're slow to wake up, could they be having a shunt failure that then led to seizures, which is not a common manifestation of shunt failure, but it's possible. So maybe they would require an ER visit and evaluation each time. So it really depends on the different situation and the underlying history and the different parties involved in who would be calling 911 and whether they would be comfortable using the rescue medication without calling 911. So I hope that kind of makes sense, but there's a lot of different complexities and different individualized situations there.
Right. So we've been talking mostly about rescue medications in the community setting, but can you briefly, and I know it's hard to do this briefly, but briefly discuss kind of the typical flow chart of treatment options used at various stages of status epilepticus in the ER and ICU setting?
Sure. So I think a lot of hospitals have pretty defined flow charts and algorithm on how to treat status epilepticus, mostly based on nationally published guidelines on how to do it. But basically, in the first 5 minutes after a seizure starts, you don't know if it's status epilepticus yet, right? Because seizures can't stop on their own. But in those 5 minutes, it's what we call the ABCs, or airway, breathing, and circulation, basic first aid. Excuse me. Timing the seizure, checking vital signs, and if the oxygen is low, then administering additional oxygen if needed. Checking a blood sugar, checking a blood test for electrolytes or other blood tests. So that's kind of what happens in the first 5 minutes if the patient is already in the ER or inpatient setting. Of course, these ABCs and such can be checked at home, but the blood test cannot. So after 5 minutes, it would be considered status epilepticus. So between 5 and 20 minutes, or at the 5-minute mark, you really want to be administering your benzodiazepine, and that could be intramuscular Midazolam, intravenous Lorazepam or Ativan, or intravenous Diazepam or Valium. Sometimes IV phenobarb or rectal Diazepam or intranasal Midazolam can be used if those first three weren't available, and you start to think about whether you need support of the patient's breathing control with a breathing tube or just with a bag and mask. So at the 20-minute point, if that benzodiazepine didn't seem to take effect, and you might repeat that benzodiazepine a couple times during those minutes, then you go to a second-line medication, and those are IV forms of anti-seizure medications like fosphenytoin, which is an IV form of Dilantin, IV valproic acid or Depakote, or IV levetiracetam or Keppra, or sometimes IV phenobarbital too. And those usually take about 20 minutes to infuse, and after those 20 minutes, so between 40 and 60 minutes, then you might repeat that second line therapy, and if that doesn't work, or you might go straight to anesthetic dose, an infusion of midazolam or Versed, or phenobarbital or propofol, another anesthetic, or pentobarbital. So those would be the progression over the first hour to try to get status epilepticus under control. At that point, you also want to put the patient on EEG monitoring to look at response to treatment with the medications. If the patient doesn't respond to the anesthetic doses of medication, then we call that refractory status epilepticus or super refractory status epilepticus. And some of these patients respond. This is pretty rare cases, but we do use the ketogenic diet sometimes for super refractory status epilepticus, and that can be helpful and can also help come off of these anesthetic medications, which is kind of a long-term goal because you can't be on an anesthetic medication forever. For those second-line medications that I talked about, the fosphenytoin, valproic acid, and levetiracetam or Keppra, it should be noted that there was a recent randomized controlled trial to try to evaluate whether one of those is better than the next. So they took 384 patients that were still having seizure activity despite the initial benzodiazepine and randomized them to one of those three medications. And what they found is that they all pretty much worked similarly, and about 50% of patients responded to the medication. And by response, they defined that as the seizure stopping and the patient having improved alertness by 60 minutes after the seizure started. They also didn't really find any big difference in adverse effects from those medications. So that's the ESET study that was done the last few years.
Okay, great. So while it's not a medication, the magnet that comes with the vagus nerve stimulator can be considered a rescue therapy. Can you just briefly describe when and how this is used and how effective it is?
Sure. Just to review that the vagal nerve stimulator is a surgically implanted device and has a generator under the skin and an electrode that goes to the vagus nerve, which is a nerve that comes from the brainstem, and it sends intermittent mild pulses of electrical stimulus, so a little pulse lasting, let's say, 30 seconds every 5 minutes or so to the vagus nerve, and that tends to decrease the amount of seizures long term. But when a seizure happens, then you can also immediately activate the vagal nerve stimulator by swiping a magnet over the generator, which signals it to give an immediate pulse of electricity that's a little bit stronger and lasts a little bit longer, like a minute instead of 30 seconds. So that can be useful for patients that can feel an aura and can abort that seizure by using the magnet, or by families of patients that are having a seizure and they can grab the magnet and swipe it over the generator and deliver a stronger pulse, and that can stop the seizure sometimes.
Okay. And we've heard some client reports of using various formulations of cannabidiol or CBD as an as-needed or rescue medication, sometimes using vaping or sublingually administered tinctures. Is there any research to support the efficacy and safety of that?
So, not that I'm aware of. It should be noted that there is pharmaceutical-grade CBD now in the form of Epidiolex, which wouldn't be sublingual or vaped. Of course, it's an oral medication, and it's a long-term daily medication, and it takes 2.5 to 5 hours for its peak to reach in the bloodstream after taking a dose, and also has a really long half-life, meaning the time at which it's eliminated, half the amount is eliminated of about 56 to 61 hours, so about 2.5 days. So vaping and sublingual administration of CBD, of course, would have a faster effect, and I think it's not unreasonable to think that it might have a rescue effect, but I'm not aware of any data to support the efficacy or safety of it. So, yeah. So I think it's a little bit up in the air in my mind.
Okay. And then lastly, are there any other rescue medications in the pipeline that our listeners might want to know about?
Yeah, there's a few different things being developed in the pipeline. So one is inhaled alprazolam. So alprazolam is known by the public more commonly as Xanax, but this is an inhaled form rather than an oral form. And it's being developed because inhaled medications go into the lungs, and the lungs are rich with capillaries, so you get a really quick absorption. And that company has done some clinical studies and found that in a phase 2 study, which mainly looks at safety and a little bit of efficacy in a small group of patients, that it could stop seizures in about 30 seconds. It's a little bit unclear to me how that would treat convulsive status epilepticus, though, because if you have to take a single normal breath, that would be hard to do in the middle of a seizure in someone that's unresponsive. But according to their website, they're planning on a phase 3 study, which is kind of the last step before getting FDA approval late this year, early next year. There are also a couple different forms of self-injectable diazepam that I mentioned earlier. So there's one that seems to have finished phase 1 studies, but seems to be stalled on phase 2, and then there's another one that seems to be in phase 3 trials now. And then finally, there's another diazepam form that can be delivered buccally, so through the cheek, with a soluble film. So it's kind of a thin film that you would flip inside your cheek, and then that could be relatively rapidly absorbed. I think that's in phase 3 trials.
Okay, and the self-injectable forms, are those intramuscular or subcutaneous or something else, or both?
I believe they're intramuscular, similar to an
Okay.
EpiPen.
Got it. Okay, so we're going to go ahead and open it up for questions, and I just want to remind everyone to please mute your lines, either using the mute feature on your phone or *6 if you're not asking a question. If you do have to ask a question, then certainly just unmute your line, ask a question, and then you can remute it. So we'll go ahead and switch. Just a moment. Oh, sorry. Let me change that. Wrong mode. Okay. Who would like to get us started with a question?
I have a question.
Go ahead.
So I know that you had said sometimes it's difficult to detect whether or not a patient is still in that post-ictal phase or still having a seizure. And I know that, knowing their typical seizure pattern would help with that. But can they just develop a different type of seizure than what they typically have?
Yeah, that's a great question, and you're absolutely right. Just because someone has had certain type of seizures in the past doesn't mean that their seizures don't change, and absolutely patients can develop new seizure types or it can be different in how those seizures look in subsequent seizures. So it often can be really hard to tell, and in the hospital setting, we often use EEG monitoring to try to make sure that the individual is no longer having a seizure after treatment. But sometimes we start to hook up the EEG, and then the patient just starts waking up and making purposeful movement or talking, and then we don't really need that EEG anymore. So it's a tricky balance sometimes to try to figure out whether someone is continuing to have seizures or is in that post-ictal state where they're not as responsive.
So I'm in a school. Oh, sorry.
No, go ahead.
I'm in a school setting. So what would you recommend for me to be able to determine that?
So I think what I would try to do is, of course, talk to the family. Potentially, the physicians can also provide some guidance too. And what I generally say is, if someone is improving and on that upward slope of becoming more awake and becoming more responsive and moving spontaneously, tracking with their eyes, maybe having some verbal outputs, or at least kind of pushing you away responsibly, and appropriately if you're trying to mess with them or tickle them, then usually those patients are in a post-ictal state rather than kind of coming back to their normal selves. So that's kind of what I would try to do in a ER setting to try to clinically figure out whether someone's kind of turning the corner or not. So it's a combination of trying to figure out what is typical for that patient, but also what you observe and what kind of trajectory that individual is on in terms of improving or just persistently not with it, or even, some people will go back into repeated seizures over and over again, and in those cases that would be when I would worry more that they're continuing to have frequent seizures.
Okay, thank you very much.
Sure.
Okay, other questions?
Yeah, Dr. Dang, this is Cindy from the foundation. Thank you. I don't know how you remembered all those onsets and elimination times, but I like to know that when I'm teaching people so they have an expectation of, time of onset of the medication when definitely something should have been working by now. But also your comment about waiting 10 minutes in non-convulsive. Am I correct as what I heard about that when assessing that issue is what you said at the beginning?
I did say that, but I'd say even more than that, it needs to be an individualized kind of decision in terms of how to wait, how long to wait.
But I really
an example. Yeah.
Right, but I really like that theory. I really do. Because so many people are ready to rush to the medication, and when you talk about injury to the brain in non-convulsive not being that typical, I think that's great. And now with the new onset of the Midazolam being a faster onset in that, it's even greater. One question I do have is with the schools, and I do quite a few teaching with schools, and it's always a fight with 911. My concern is, and I'm not Valtoco or Midazolam either way, okay, whatever works for the person, but when you're getting up to those high school ages and you're getting the larger kids. And when we were giving the old Versed, when we were drawing it up and doing it through the Mad Atomizer, we were giving larger doses. And with that 5 milligram dosage, waiting 10 milligrams. Oh, when we're doing the 5 milligram dosage for the older kids, and then you have to wait, according to the manufacturer, 10 minutes and give a second 5 milligram dosage. I'm concerned with schools and them going, okay, we've given the 5 milligrams, let's call 911. And that is an issue that I know we're going to face, and I don't know how we can overcome that with schools and them knowing that 5 milligrams is not that big of a dose, because they're going to want to call 911 right away.
Right. Yeah, no, that's a really good point, and I guess you've worked with the schools, and I thank you for that because it's really helpful for the families, patients, and for us providers too. And I think we'll have to see what happens with these new medications too, because I also worry a little bit that 5 milligrams won't be enough for a lot of patients.
Yes.
And that they'll still be in convulsive status. And if they are still in convulsive status after another 5 minutes, despite that first dose of Midazolam, then maybe I think in that case 911 should be called if they're still in convulsive status. If they're out of status with the 5 milligrams, then depending on the situation, but I don't think 911 necessarily would have to be called there. I totally agree that
it's good. It's going to be a hard. Yeah. Also, one last thing about rescue meds and weaning of medications. Great time for a rescue med. We think it's time to wean this kid off medications, but let's keep it there. Febrile seizures. I do a lot of teaching with febrile, and that's still the usage for Diazepam because that's under the age. But there's a lot of traveling. Hey, I go down to the Caribbean. I'm going to take my rescue med with me on the plane. There's a lot of advantages to this. So
it's all very good.
Yeah.
Okay. Other questions?
I would like. I'm fortunate enough to work in a district. I'm the district nurse. We actually have two nurses in our district. And I have two things to say. One, I think it's going to be difficult to ask a school that doesn't have any nursing staff that is readily available to make that assessment, to say not to call. I mean, I'm comfortable assessing a patient and saying that they may not need to go to the hospital after they've had a dose of their rescue medication if it's not called for in the health plan. But I think it'll be hard until we get more school nurses in Michigan to expect schools to make an assessment that a clinician would find difficult to make. So that's unfortunate, but we just need more school nurses across the board. My other question is, will this be available? Will this presentation be available, or could this be made available as a presentation? Because I think that the information that you presented here is fantastic. I'm a newer school nurse. I started last year, and in all of my nursing career, I had never encountered I didn't know what a vagal nerve stimulator was. I learned a lot last year, and I think this would be fantastic when we have paraprofessionals who are excellent at what they do, and but there is a lot of turnover, and to have this information as a basic lesson would, I think, be fantastic. So I don't know if that's something that could be done, or you'd be willing to do.
Yes.
Or just throwing it out there.
Absolutely. We are. All of these are recorded, and it will be uploaded to our website and YouTube channel probably by the end of the week. So.
Fantastic. Okay.
Yeah, if you'd like to even send me an email just to remind me to send you the link, you can do that. And I would strongly encourage, if you want to even share it with the Michigan Association of School Nurses and have them distribute it to their email list or anything like that, we'd be happy to get this information out. So.
Okay.
Great.
Thank you.
Okay, other questions? Yeah,
I'd
go ahead.
also plug, Russ, just wanted to plug the epilepsy.com website too. I do it a lot with my patients, but I think there's a lot of really good information on that website, including seizure first aid and safety, and there's some videos on that website too. There's actually a video, I think, on rescue medications too, which covered a lot of the same things that I covered, but with visuals and PowerPoint slides too, which might also be a good resource and helpful.
That's a great point. Yeah, a lot of great information there. Videos on how to administer, videos on a recent webinar that was on precisely this topic. So yeah, excellent. Okay, other questions? We have about a couple minutes left.
I have a quick question on, you touched base on how these benzos can be readily absorbed by the body, but are there any particular benzos that you have to be careful about that still, even though that it's readily absorbed into the blood, does it still have to be, any of this benzos particularly still have to be further metabolized to make them effective? That may slow down the process.
Good question.
Yeah, that's a great question. So all of these benzodiazepines are active in their native form. They don't need to be activated in any way to a different form for it to act in the brain. There are some that are metabolized that have active metabolites still, but the initial drug is active in all these cases.
Okay, great question. All right, well, we are at 1:30, so I want to thank you, Dr. Dang, for a very thorough and informative and timely presentation. So, and thank you, everyone, for participating. And like I mentioned, this will be uploaded to our website on the Learn and Share conference call page, and also to our YouTube channel, so that can be listened to and shared for future reference. So again, thank you all for joining us. Thank you, Dr. Dang. And
thank you.
Yeah, and our next call is on July 1st on epilepsy and employment, how vocational rehabilitation can help. So anyone who's interested in that can register, and we hope you can join us. Thanks again, Dr. Dang, and thanks everyone for joining us, and we'll talk to you soon.
Thank you, everybody.
Thank you.